Welcome, everybody. Hello, I'm Jasmine Arazi, Program Manager here at IPFCC. And today I'm joined by my colleague, Marie Abraham, our Vice President of Programming and Publications. And also with us is Bev Johnson, our President and Chief Executive Officer. Today, providing expert technical support is our colleague, Matt Da Silva. And today's discussion is titled Better Together, Supporting Family Presence and Participation. We are very excited to see how many of you are here. We can see that this is a topic of significant interest. As people are joining in, please feel free to chat in your name, organization, and where you are located. We are recording the conversation so that we can share that with others who registered for the recording and also post it on our website. Just a reminder, while we like seeing faces, if you prefer, you can go off camera. Next slide. We want to acknowledge our PFCC Connect sponsors. Thank you to Emory Healthcare, Providence Healthcare, and University Health for your continued support. Thank you. Next slide. As you all know, our conversations are intended to be interactive and informative. We will share some slides to set the context and provide information to get the conversation going, but then we'll dive right into discussion. We do want to remind everyone of our group agreements here. Be as present as possible. When we move to discussion, it would be great if you could turn on your video. Participate actively. We encourage you to be curious, to ask questions, but also share your experiences, perspectives, and any challenges that you have faced. You can either chat that in or participate verbally by raising your hand and waiting to be called on. Let's share this space. Let's allow others to contribute to the conversation as well. And embrace a learning and growth mindset. We know that all of you bring expertise and we all have so much to learn from each other. And finally, we hope that you enjoy the discussion and have fun. If at any moment you experience any technical issue, you can chat directly with Matt Da Silva. Thank you.
Thanks, Jasmine. And thanks to all of you who registered for sharing the questions and as well as ideas for this topic. It always helps us out to see what you're interested in. And we know the pandemic had such a significant impact on family presence. And from what I was reading in the responses, I feel like we need to get back to normal. Like this is not normal. And so we need to help you do that. And you need to help all of us. Here are some of the things, so some of the issues that we heard about and what you're most interested in. So what are best practices to encourage leaders and staff to support family presence? How can family presence be balanced with safety, especially during times like another pandemic or an RSV season? How can we develop family presence policies that will be accepted by leaders, clinicians, and staff and consistently implemented in units as well as across the system? What strategies can we implement to address the challenges we're facing? A lot of you are facing challenges to family presence. So what can we do what strategies are useful for that? And then how do we plan for the next pandemic or other similar situations that will impact family presence? So those are just, a number of interesting issues that came up. And I'm just going to now, with great pleasure, hand it off to Bev Johnson, who brings decades of expertise in this topic. Bev?
Thanks, Marie. These are really wonderful issues that you all generated, really thoughtful, that I think will help us discuss it today, but also for you to take back and think about as you work to bring about change and improvement in your um, organizations. Next slide. As before we really begin to talk about next steps, I'd love to share a personal experience. Family presence and family participation have been just um, so important to me as an individual, as a family member, almost my entire life. And I think that we learned so much during the Better Together campaign that was launched in 2014, but we lost a great deal during COVID. My husband had spinal surgery in January. So, like almost anybody going to a hospital, I checked on the website to see about, quote, visiting hours. And I was horrified to note that they had very rigid visiting hours. And there was no mention that a family had anything to contribute to the quality and safety of care. There was just, you know, they were controlled and not really a significant part of the process. I asked the surgeon if, how I could participate in my husband's care as a care partner. He said, "Oh, there'll be no problem. There's a bed for you, etc." And it turned out we had excellent care, and that was really true. But I don't think I'm a normal person. I work inside of healthcare, and I think we are very intimidated when our websites don't speak positively and welcoming to care partners and families as to be part of the process. So that's a beginning. Um, Thinking about next steps. So each of you may have personal experiences too that you can bring to this discussion today. Next slide, please. So let's think about it with the current realities. And it'd be interesting. This is what we're seeing at IPFCC, that for so many hospitals and health systems, you're struggling with the workforce, that you lost probably, as much as 20% of the workforce during the pandemic. That's a huge changeover in staff. And the current workforce is really not as experienced in PFCC concepts. They not don't have all the skills and experience of collaborating successfully with patients and families. Many healthcare organizations that we've been working with are really struggling to just hire sufficient numbers of people, and then to try to build on their skills. And then, of course, because of the trauma of COVID, many staff and clinicians experience post-traumatic stress disorder. So the mental health of the workforce is really challenging still. And then think about it from patients and families and the communities you serve. Everyone was traumatized by COVID. And then on top of that, if you had hospital experiences when you were forcibly separated from your loved ones, it was a very scary time, whether you were a patient or a family. And what we've seen is a real loss in trust in the healthcare system. And I can speak particularly for the United States. I'm not sure other countries have this divisiveness that we have right now. And there's really a lack of civility to how we talk to each other. And I think that speaks to a need to begin to prepare people how you have conversations that can be constructive, supportive, and really helpful to care. And, lastly, patients and families out there really haven't been prepared and had experience with positive partnerships with staff and clinicians. So we really, in many ways, are starting over again, but building on what we've learned over many decades. Next. So I think a first step for you all when you go back is to look at your current policy and practice. You know, look at your visiting policy and see what it really says. And I put visitation and visiting all in quotation marks, because what we really are talking about is the presence and participation of family or a trusted friend, a care partner. And so you want to see how it defines family, whether there is a recognition that they're, as Canada has taught us, social visitors, and then they're care partners. And I think that's a distinction that can help as you go forward. Then look at your website, just like I did with my husband's surgery, and see what it communicates. Can you find information? And what does it really say about the role of the patient and family and any care partners? And look at your patient and family handbook. So those patient-facing tools that you have. I think it's always great to do a walkabout and look at the signage throughout your organization. Some people say, oh, we just ignore the signs, but they can be real barriers to people. What about having it welcoming and in different languages, and to say you are an important part of the care team right before they even are in a patient room or in a clinic room? And then also look at how is the policy communicated in orientation to new staff, clinicians, trainees, and even in your nurse residency and preceptor programs, because that is the way you infuse it in a culture. Next. Then you all raise the issue of family presence and safety. And we really learned during COVID that there was tremendous harm because families or care partners could not be present for the most part across the pandemic. Our friends in Canada at Healthcare Excellence Canada have done some amazing work around really defining essential care partners and how they can safely be involved. And there are lots of tools on their website, and I encourage you, it translates across countries. I encourage you to visit and adapt them so they work well with wherever you happen to be. There also was a really interesting short article by Tejal Gandhi in the Joint Commission Journal on Quality and Safety in 2022. So think about that relative to the pandemic. You know, as it was winding down, the article is entitled, "Don't Go to the Hospital Alone." And we just know that's safe practice. And she goes on to say family members provide an important safety net for patients in the hospital and across the entire continuum of care. In the article, I've given you a link. Next slide. She does have a table on the harms that were caused from several studies of lack of family presence during the pandemic. Delays in diagnosis, falls, clinical deterioration. Often it's the loved one who notices a change, a subtle change. So something can be done about it earlier. And then certainly transitions of care. You can't safely go home when you're in pain, you're on medication, you haven't been able to track a lot of what has been shared with you. And to think that families or the care partner is an important, essential part of transitions of care. So I hope those articles will be useful. Next slide. So a best practice in getting to change policy, program, and practice is to put together an interdisciplinary work group that's really charged with looking at your current family presence and participation policies and developing strategies to bring about change so that you really are supporting essential care partners with the patient. I would encourage you, of course, to have patient and family partners part of this interdisciplinary work group, at least one leader, and people from quality improvement could be really useful. Maybe you want someone from patient safety as well, marketing, communications, and even security helps from the very beginning. or you can do some of the work and then bring them in, because they're an important part of making this work well. And then really look at your policies and practices and your information and education materials. Really review everything with the opportunity. Can we proactively do some information and education sharing with people to help them be better prepared for partnership? And then what we found in a number of organizations in the past year or so, actually we found it early on in the Better Together campaign, but it's really come back after the pandemic, is to try to identify a pilot unit that might be particularly ready to implement family presence and participation. If there's so much resistance, I would wait and let others test it out and begin to get comfortable with this way of working. Next slide. So this weekend, I have to confess, I had the list of all of you who are joining us today, and I poked around on everybody's website, or at least a whole lot of websites, which was really fun in some ways and discouraging in others. But I encourage you to do the same thing. Medical University of South Carolina shared their a profile on how they've gone about supporting family presence and participation. And they've anchored it all in their commitment to patient and family-centered care. So this is a little clip from their website. I noticed in Canada, there were many websites that just made this statement: we are committed to patient and family-centered care, and your family and your care partners are an essential part of your care. And it just was front and center in many of the Canadian websites. We have a profile on in the Better Together section of the website on MUSC, and we have a brand new one from the Michigan Medicine that has just been posted. So you might want to see that. And we're looking to expand that section of Better Together. So if you want to share a profile with us, we'd be delighted to see it. And then Johns Hopkins Medicine, I was hoping they could join us today, but they're not able. Maybe some people are here from Hopkins, but my husband and I, again, were at a visit at Hopkins as an outpatient. And I walked down the corridor and I got to security, and I was just delighted to see care partner and visiting hours. Well, care partners can be there 24/7, but they made that distinction in their policies and in their signage that they're care partners, and then they're, as Canada says, social visitors. And they also have these huge signs in the lobby. There's one on patient and family-centered care. There's one on collaboration. They're about 8 feet tall. And so they're teaching the public the standard of care. This is how we work together here. So I think those are positive signs that you might want to replicate. Next slide. You all asked a very terrific question about how to prepare for the next pandemic. And towards the end of this with COVID, we worked with Sherry Perkins, who is a nurse, who is the CEO of Anne Arundel Medical Center, part of the Luminous Health System in Maryland. And she's been a longtime leader in commitment to patient and family-centered practice, and was really distressed what was happening in the pandemic. And this article describes their process of getting in the hospital incident command structure. And I think across countries, this is the key committee that's working to make decisions during crisis times. And usually their priorities are safe spaces, safe staffing, safe supplies, safe equipment. But they've added here safe family presence. So to be central to the work they're doing, again, preventing harm, and the key leaders part of an incident command structure are usually those people in infectious disease. They may have legal, they have ethics and other medical leadership. So you want to make sure that they understand it. It was really interesting work to work with Deborah Dokken, who I think has joined us today, was such a leader in the Better Together campaign. But we worked with an amazing ethicist from Canada to really look at family presence during a pandemic and to develop some guidance for decision making. And while this was done specifically for the pandemic, I think you could bring this out. It's free, it's on our website, and really look at it in terms of current realities today. Because PFCC core concepts of dignity and respect, information sharing, patient and family participation in care and decision-making and collaboration really align with bioethical principles. And so if we're going to get to mutually beneficial partnerships, we really need to look at how are we setting this up for family presence and participation. So I hope those are helpful resources. And I'm just excited to join in the conversation with you about next steps and what your perceptions are. I turn it back to you, Marie, I think. And
Sure. Yep. And Matt, we're going to start the discussion. Yep. So you can take the slides down and welcome everyone. And Bev, we do have Stacy Colomer from Johns Hopkins here. So I don't know.
great.
I don't know,
Oh,
Stacy,
so
if you want to jump
wonderful.
on and say anything about the great work that Johns Hopkins is doing.
And if she's not able to talk, they also wrote a wonderful article about their care partner policy that we may be able to find that link. I'm pretty sure it's in that ethical decision-making book, Jasmine, if it's not on the list, but we can send it out to you after this call as well.
Yep.
Any thoughts of what you all are finding and what it's like in your
We did have some people comment about the importance of family members being with the patient, and I think they weren't very positive stories. It was more the things that can go wrong when families aren't present at the bedside. So I don't know if anybody, Teresa, if you wanted to talk about it or anybody else.
I'm happy to share. So in the end of 21 into 22, my mother was admitted. So, we were in the middle of COVID, so to speak. And my father was her main caregiver. However, my father was very hard of hearing. And so he, like most stoic gentlemen, he would just answer yes or say uh-huh and not really know and not really know a lot about the medical field as far as the ICU side of things. And so they at one point the uh, adult care facility, I work in pediatrics, so it's much different, but the adult care facility um, they were very strong armed about who they were going to let back. And I informed them that I was my father's caregiver as he was my mother's, and that I needed to be there whenever medical conversations were taking place, so that I could help him understand and hear what was going on. But there was an instance that my mother had had a trach and a G tube placed, and this was again at the end of 2021, and there was a cap placed on her tray for capping off the trach. And so a staff member saw it laying there because I had questioned what it was there for. and she said, "Oh, this goes on the G2 or on the trach." She went and placed it on the trach, and had I not been there, I progressively watched her respirations get fainter and fainter. And I called back in. A different nurse came in and said, "Oh, that's not supposed to go on there." So needless to say, it was there were some very rough times that, you know, a family being present was a must. And I think I have to say pediatrics does a much better job at recognizing that than the adult care system. Because, and I'll cut this short, but I had the opportunity when we were looking for um, a rehabilitation service area for her to go. Um, they had nothing on the wall. They had no clocks. They had no care signs, nothing telling you what the plan of day was or even what time of the day it was. And I shared with them that I would love to partner with them and give them some feedback on, how it could make things go better. And it was like I had three heads. Since both of my parents passed away 4 days apart, but um,
Yeah.
I really got a wake up call due to the adult facilities and how they don't value as much the family participation and how it is so needed.
And,
Thank you. Thank you very much, Teresa.
and I think, thank you for sharing that. And, often, even though your father might not have understood things, he probably was an emotional support for your mom as well. And that's critical. So when we're working with hospitals, we often talk about designating one or two care partners. One, they can't always be there, but there may be different roles that they play, and sort of that emotional healing is important, but someone else, and not everyone's going to have a nurse daughter. So it's, but I think some of you've talked about the resistance, and it's real, and we need to teach everybody on all sides. Pediatrics did better during the pandemic. So thank you. Thank you for that.
Emily, would you like to share something briefly?
Yes, I worked at Kaiser Permanente when the pandemic hit, and I was on a team that was empowered to call family members when someone was administered to the hospital, because we weren't allowing the family members to come in. And it was, of course, people were angry and sad and also grateful. And we were also able to give them information about, here's how you can find out about how your family member is doing. And I think I would love it if that kind of a blanket thing wasn't needed the next time something like this happened. But we'll have to think about important things like that. How do you let people know what is allowed and what's not? How do we make it easy for family members, even if they can't come in certain circumstances, to get the updates on their patients, things like that, so people aren't just left in the dark. Those were some of the most important positive responses we get. Thank you for letting me know, so I didn't drive an hour each way only to come to the hospital and find out I couldn't come in. Those are my thoughts.
Thank you. There were lots of positive learnings from the pandemic. And I think one, our use of telehealth in some ways, your phone calls going back to people, but that we could today now involve families who either don't live in the city, but are going to help in the transition of home, to bring them in for rounds or for a change of shift where you're planning something. That would really help greatly in terms of looping families back in a positive way. Great. I think there's another comment.
Barbara?
Yes, thank you very much for this.
Good to
It's
see you.
so interesting. Yes, thank you. So I had someone who had had a heart attack and was taken to the hospital, and he was put on a heart monitor, and the heart monitor fell off for 6 hours. Had I been there, that would have never happened. His IV came out and he actually sent me pictures of blood all over the bed and all over the floor. Something else that would not have happened. So I appreciate your attention to this. But I wanted to ask a question. Has the harm been quantified as to what happened during the pandemic? I know you mentioned the article with a few anecdotes about things that had happened, but has it been quantified?
Yes, those articles that pay harm is did increase during the pandemic. So those are just two articles where you can see some studies about it. So they were trying to say, where are the issues? But the patient safety stats, really did show that. I think it was understandable at the beginning of the pandemic. Nobody knew what this virus was. We didn't know how to manage it, but we should have learned more quickly. We should have had more in-depth responses of how could we keep people safe and prevent the spread of infection. And pediatrics did somewhat better than, I think they did a lot better. Wouldn't you agree, Marie, that they did a lot better than the adult world? And just because, I think we've learned that older people of all ages need somebody there.
Mhm. Yes, thank you very much.
Thanks, Barbara.
Thanks. So we're getting some good comments in here, and I'm wondering if anyone would like to speak to those comments. Jennifer, you have a great idea about writing down the info for families. Do you want to
Can I tell you something that happened in my care, if you don't mind?
Sure.
Because my
Absolutely.
bar is not working for some reason. When I was in hospital, I've got two daughters who are in healthcare, and I was very ill, and the doctor would come in and go, blah, 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 that stuff like that. So I said to them, do you mind if I record this on my iPhone? And then I could send it to my daughters who are in healthcare, and they knew what the blah, blah was all about. I didn't have one physician say no. So as a coping skill for people who can't be there, and I've never had anyone say no, they can't do this. Just to say, can the patient record this so we can send it and keep it, not in a litigation point of view, but so the family could understand what's happened to the patient. Thank you.
Vic, that is such a great idea. I'm delighted they didn't say, no, I'm sorry, you can't record it. We, early in the years when we were working a lot in pediatrics with children with special health needs, we were encouraging clinicians to support families in really making a audio recording or video recording so they could show the caregivers back in the community how to do certain things. But there was a lot of tension about it, but that's, I think it's lovely if they would agree to do that. Other comments?
Take it that I didn't ask permission.
I think that was great.
You just say, I'm going to record this so that my family can understand what's happening to me,
Oh, that's
as opposed
great.
to may I. But nobody said, no, you can't do that. Right.
Great. It's hard, even if you're a health professional and you're the patient, to really retain all that you hear and to know. And so we're encouraging people to designate a care partner in an outpatient setting, in an emergency room setting, and that name can follow you. It can be changed in the chart, but it's really important to have somebody already designated so that they're able to participate. Other thoughts in the chat, Marie?
Yeah, I just want to bring to the group because Kelly's having issues with her mic not working. However, that she was a social worker at a local nursing home, and we had the opposite effect as we listened to our patients. We had a resident who really struggled and had horrible behaviors during the pandemic, and we ended up calling the HCP care partner who gave us ideas on how to redirect their mother And then I created the residence care plan to reflect what the caregiver told us, and it was a very successful care plan. So thank you, Kelly, for sharing that.
That sounds like it's a long-term care community. That's a wonderful
Yeah.
addition to.
Erica, did you want to speak or, oh, I'm sorry. I see Brian has his hand up. Let's go to Brian and then.
Yeah, hi, Brian Isaacs. I'm a pharmacist and also a professor at the University of Minnesota College of Pharmacy. I know Bev Johnson from way back when I did a extended sabbatical at CMS in Baltimore. We worked on decreasing hospital-acquired conditions, Bev, as you know very well. And we made some really great progress. And at the time, medications, adverse drug events were the #1 hospital-acquired conditions. They're no longer #1. Yay, we're #2. I guess pressure ulcers have overtaken us. But really, I want to share. I also have a personal story of some of the medication safety concerns in hospitals. My mother-in-law was in, and my wife will never let her mother stay in the hospital a single moment unless she's there. And a good thing, one night she was sleeping in the bed, and the nurse came in and said, "Oh, hello, Mrs. Peterson. Well, here's your insulin." Well, and she's like, my wife woke up, said, "She's not diabetic. Stop it." They would have given her insulin, hypoglycemic episode. So we've all got those stories. But really, let's look at the positive here. Is that what I dropped into the chat here is something that was developed by the Geriatric Workforce Enhancement Program. These are grants that are offered by HRSA, the Health Resources and Services Administration, to 40-some of these geriatric workforce enhancement programs across the country. So we developed this effective medication self-management toolkit that really is intended both for patients, families, and healthcare providers. Because right now, all we do really is throw drugs at patients without that understanding of why you're taking it, what it's supposed to do for you, and what safety concerns are specific to that. And we tested this out in focus group sessions, in independent senior living facilities, and it worked like a charm. So please go ahead and look at that. It's got some pretty funny, I say funny animated patient case scenarios, but also some, what do you ask, the 4-step process for each medication you're on. So please share that and with your loved ones.
So is that in a link in the chat?
Yes.
Can't see all the chat. Great. Well, I think that could really help give something tangible to patients and families.
Well, that's just it, Bev. We have to offer something, and so something positive that's working, because we all have these horror stories, and it shouldn't be that way. But you know what? That's the state of affairs. Let's work around it.
Mm-hmm. Thank you. It also really links so much to safety and family presence and safety. So, Jennifer, and then Lillian, I'll come to you.
Yeah, I was just sharing that my one suggestion had been about trying to normalize writing down information for patients and their families. I'm a parent of a couple of kids with special healthcare needs, as well as an OT in an acute setting. And I've really tried to, when I have families, when I work with adults, asking them, do you want me to write this information down for you? Because we all know when you're under stress, whether it's the family or the patient, you're only collecting a portion of that information and then also reviewing it again with them to make sure they can read and understand your writing. I know it takes more time, but I think that is one of the ways that we can really prevent future, readmissions as well as medical errors.
Thank you,
That's
Jennifer.
A great suggestion, and maybe giving even a tool that to encourage them to take their own notes. And
yes, I usually provide some paper and a pen or a pencil, and I encourage them to write everything down, but then also whatever they write down, I instruct them to repeat back to whatever provider they're speaking to make sure that they have the correct information written down. And so the provider knows what they know as well and what they need to clarify on.
Mm-hmm.
Best practice.
Lillian.
Hi, I wanted to comment on what the gentleman was saying about medicines and stuff, because I think that a lot of times when you go to a provider, I know this happens to me, are all your medications the same? And, you nod and say, sure. Well, really, we should be going over them, like he said, one after the other, just to make sure. There was a time that my father-in-law was on 3 different beta blockers. and his blood pressure was always low, and he was 80 years old. And, you know, no wonder he's having vascular dementia. His blood pressure was too low to perfuse his brain. And, you know, I am the one that figured that out, that he was on too many meds. And I happened to be in the office one time when they just asked the question, is everything the same? And of course he nodded. And in a 5-minute interlude, people with slight dementia can fake it beautifully. But, you know, he really was not a good historian. And then another thing that I wanted to say in response to the young lady that spoke just before me is we have just rolled out this patient and family journal at Children's Memorial Hermann, and there are about 10 pages in the middle of it that has the care team, the night nurse, the day nurse, the respiratory social work case manager, etc. The plan of care for my child, the questions for the care team, responses. Today, my child is acting, and fill in the blank. And then just a summary for the day. And there are like 10 of those pages. But also, one of the things that's in the first few pages is how to talk to the care team. Because as healthcare providers, we go in and we give a dissertation to these people, whether it's a patient or a parent, and we tell them, okay, do you have any questions, as we're walking out the door? Well, I have found in my work with pediatrics that the biggest question is, can you repeat that 17 times? And so they don't know what questions to ask. So we started, so we put a list together. You know, what's our goal? How are we going to get to this goal? And actually it's, what's the next big goal? How will the goal be accomplished? What is the plan if it cannot be accomplished? And can I have a summary of what was discussed during rounds if people are not there? You know, because when kids are in the hospital for a long time, somebody still has to pay the mortgage. So a lot of times the parents are not there because, you know, they know their child is safe and taken care of. And so they have to call in, or we call them. And so anyway, I just wanted to share that, you know, I'm going around to educate, in addition to our folder full of goodies that we give to parents. They also now have this journal so that the staff can speak to it as well. I'll let you know how it goes.
Yeah, Lillian, we had a question for you about that. Is that guide or resource available to others, or is that something just in your system?
It is in my system, but I have the file. I'm happy to share it, and you guys can alter it however you like. There's no need to reinvent the wheel.
Great, thank you.
I don't know if I know how to do it in the chat under pressure.
Oh, no, don't worry about it.
But
You can,
I can send it to you
just,
guys.
yeah, you can just email it to me, and we'll talk about that at the very end of the session.
Okay, cool.
Thank you.
Yeah, if I try to figure it out, I'm going to miss the rest of the meeting.
And Lillian, go ahead.
No,
Marie.
go ahead.
I really like that idea because you're teaching families how to have conversations with healthcare professionals. And I think we should do parallel for staff in terms of, and this is pediatrics, but geriatrics or anywhere in between, that how can we talk with each other in mutually beneficial ways? You know, it's, we've had some stories about how, you know, things happen because people are so busy in hospitals today. It's really hard to give the kind of care you really want to give. And so we need to teach on both sides, and that idea of simple outline, writing it down. The last two of you really, you know, said that we need to make it okay to learn together to talk about these kinds of things.
We're also working on a whiteboard project as well, where the medical teams that are rounding the doctors are actually writing their plan on the board instead of leaving it to the nurse to hopefully be able to be there during rounds, which they try to be, but you know, they have other patients and
they're
teams.
welcome to be there and participate.
Yeah. Oh, yeah. The families are there. The team goes into the room. They talk with the family, and the providers write a couple of the daily goals right there on the board in the moment.
Marie has just posted, I think it's up there, or is it still under review, some new guidance, updated guidance and articles on rounds and
Yep.
family
Yeah,
participation.
no, it's there. You're just reminding me, Bev, when you were speaking about the two different guides we had, one for in the Better Together toolkit, one for the staff and one for the patients and families. So I think that's something that will, and again, we'll talk about that at the end of the session. Patricia, you've been waiting very patiently.
Yeah, I'm from Ottawa, Canada. And now I'm a patient partner advisor, whatever you want to call it, at the Ottawa Hospital, which is the major trauma hospital in the area. We have a very active essential care partner program. It was started actually during COVID because the ethicists felt there was a rather serious problem with people not being able to visit or to be with their loved ones. I can only say that much. I was rather hoping our patient engagement person would be on, so she could tell you exactly how that works. It works through all the hospitals within the area and some just outside. It assures or ensures that the patient will always have somebody knowledgeable with them at the bedside. That's the niche part of the Essential Care Partner Program, and that is the title of it. I can send you the name of the person who could comment on that more better than I could. I would also like to say, because I noticed somebody put in, we have electronic medical records. I am a single person and older. And I make sure that I choose the option that she shares everything and has legal access to my records so that she knows what's going on with me all the time, which I would recommend to anybody who uses an electronic medical record. I think that's extremely important. And the last thing I would say is I think the one thing we haven't talked about here is what I saw really as the biggest disaster was the long-term care homes. I think that I'm a volunteer at a long-term care home. I think that most of the residents in these homes not being able to have access to their loved ones in what essentially is probably the last part of their lives was an absolute disaster. And I think we need to make absolutely sure that never happens again. Thank you. That's it.
Patricia, I'd love to comment on the three important things you talked about. First, with long-term care, we do have some guidance on our website about it. I couldn't agree with you more. And Healthcare Excellence Canada also had, like your essential care partner for acute care, they have a wonderful program for long-term care as well. And we have so much work to do about building partnerships with families and residents in long-term care for their safety and well-being and really mental health. I go to the Ottawa website often because I loved the video that you all used and the way you described the role of essential care partners. I would love for you to make a broader video, and maybe I haven't found it yet, that not only shows family members how to be safe in terms of an infectious disease and hand washing and mask and gown and all of that, but how can they, what we were talking about before, have productive conversations with the care team. And so picking up on that idea Maurice shared a few minutes ago, those Better Together short checklists.
Yes.
If we
Yeah.
could figure out a way to model that in short videos, I'd love for people everybody should see it before they have a
Okay.
loved one in the hospital. So thank you
All
for
right.
that.
I'll
And,
speak to them about it. Yeah.
and then the shared access for the electronic health record.
Mm.
We just I think it was the current issue in Pinwheel Pages, had some information about that. So some people know it as proxy access. Epic has just changed in calling it, which I think is much better, shared access. So a trusted friend or family member can have access. And I think it is, again, another safety. And I'm so glad that's what you have done. And they're trying to make it easier. So look at the newsletter, and there's some toolkits on how you can help organizations make shared access easier for people.
Right. Thank you.
Yep. I'm going to probably not pronounce your name right, but Matana or Matna, I know you had your hand up for a while. Did you want to, and you put something in the chat, but did you want to say something? Nope. Okay. We're getting close to time. Are there any other thoughts? The chat has been very rich. And Patricia, did you have one more thing to say before we?
Yeah, just one more thing is that as part of what the pharmacist mentioned, just very briefly, a couple of years ago, pre-COVID, the Ottawa Hospital here did a study where nurse practitioners or nurses would call any patient discharged from the hospital within 24 hours. The biggest complaint through the whole thing was that the people discharged did not understand their medications, which I think is something we all have to think about. That means the person giving the information, whether it was a nurse or an assistant or somebody, didn't use teach back or whatever to make sure the person understood when they left, and also didn't tell the loved one with them.
Yeah, thank you, Patricia. Please tap that resource. That'll help that I put in there. That will help a lot.
And just an idea from a number of years ago from a PFAC in Boston, the Patient Family Advisory Council said we need more useful information about meds. And when you're teaching us about the meds in the hospital, we need a certain level of information. But what they wanted was the refrigerator list. And that was the simple list to know the name of the medication, when to take it, how to take it, and anything to, to watch for. And it would be a very, like a simple poster. And that could be so possible. So check out Brian's things and think about other ideas, because it's a key safety issue. Looks like Fran has.
Fran, did you want to say something before we close up this meeting?
And my video is frozen, I apologize. But at any rate, as I've been listening to the conversation about tape recording sessions and so on, another use for tapes is like when I've had physical therapy, they will record me doing the exercise with the auditory guidance of the therapist. And you think you know what you're doing, and then you get home and you go, well, how did I do this, that, and the other? I'm thinking that that's also helpful for other self-care things that you learn in the hospital that you're going to need to do at home. So it's not just the doctor talking to you, but a video of you doing something that you need to make sure you do correctly and consistently.
Terrific.
Thank you. Okay, Matt, do you want to put up the slides just to close us out? Great, and go to the next slide. So we have 2 slides here that just have the links to all the resources that we were talking about in today's session, that great session that Bev did. So, but again, we want to hear about other resources. Matt, you can go ahead to the next slide. We want to hear about the resources that you have, like policies, or as Bev said, we are looking for places that are doing great work and would love to have a profile developed. So if that's something that you're interested in, let us know. But if you have any resources, and I know we have some in the chat, so that's great. We'll send them to me, and I'll make sure that we get them up. Next slide. So if you're not a member, please, we encourage you to join PFCC Connect. You don't have to, it's free. It's an online learning community, and you can access great information. We share ideas, people post questions, they get answers from other people. So it's just a wonderful opportunity to learn from others, to share with others, to get some resources. And if you want, we can continue these conversations that we have here in that. Next slide. So we ask that you complete the survey. We use these results to help us improve our conversations and think about future topics. So you can use the link, and Jasmine just put it in the chat, or you can use the QR code to access the survey. The link will also be shared in a post session email coming from us. Next slide. Okay, I know people said it's too short. They wish we had more time, and I agree with you. So we will hold the next informal conversation in November. The date and topic will be determined at some point. And as Jasmine said, the recording, the slides, the chat will be posted on the PFCC Connect site. So you can, if you have somebody that you want to listen to the recording, feel free to share that with people. And then, as we've already talked about, just send resources to us so we can share with others, and then continue the conversation in PFCC Connect. And if you have anything, you can, my email is right there. Please feel free to directly email me any resources or links. Well, with that, I want to thank all of you so much for participating today, and I wish you all a very good afternoon. Thank you.